Hi guys, I'm Dr. John. Welcome to the Voyage Clinics podcast, where our mission is to bring knowledge and learning to our communities in all the good ways. Today, just 3 hours ago, Charlie Kirk was shot at a university, literally a couple miles from our office. Super tragic, young family. He's a political activist. They were having some discussion and he was shot in the neck. Some of my patients were there. They saw it. It was very traumatic. I don't know. Last week we spoke about the polarization of America through the algorithms. And we were largely just talking about medical knowledge and science and things. But the political algorithms are there as well. And they're really designed to destroy, to create polarization of thinking, like this is the only way that's right, and this is the only way that's right. And to create dissent and divide and then tragedy like these. And it's just horrible. And so, again, I would nudge us as listeners to consider the algorithms. Consider what is being put in front of you, what you are being fed. It is psychological warfare, but it's money-driven because our algorithms are money-driven algorithms. How do I get people to click on this thing? They call it like rage clicking or whatever. And if you get somebody angry, their propensity to comment and like and angry face and do all the things is really high. And so that creates more money for the people that create those clickbait things. So my heart goes out to this family. It's super hard. Just know what's going on in your brain and know that there are forces at work that are pushing you around. They're algorithmically indoctrinating you to think and behave a certain way, and you gotta fight against that. So just want to bring some, I don't know all the details of anything about any of it, or if this was related to what I'm talking about, but I certainly see it. I see some of my patients being polarized and indoctrinated a certain way and against certain, things or for certain things, and algorithmically being pushed in those directions. And so, again, my heart goes out to Charlie Kirk. That's super hard. Let's shift gears a little bit today. We're going to talk about some really cool things. And Marilyn and I have been working together for a long time. And Marilyn is one of my favorite people. She's a nurse practitioner, but she and I also are quite knowledgeable about, we're going to talk about hormones. We're going to talk about low testosterone. We're going to talk about menopause, perimenopause, the roles that these hormones play in our bodies, like what they do, how they can help us. Are there risks to some of them? What are those risks? What do they kind of look like? And when should we be cautious about them? Things like that. So, with no further ado, Marilyn Sorensen, welcome to our podcast.
Thank you. It's always fun to be with you, John.
You're so fun.
It's a voyage.
I think of all the laughs that I've ever heard, yours is my favorite. I love your laugh. It's so cute. Let's talk shop. Where do you want to start on our hormone journey? Do you want to talk? Where do you want to start?
Well, hormones are used for a lot of different things in a lot of different age groups. So to set the baseline, I like to use hormones in the natural form, which is bioidentical hormones.
Yep.
That's the same chemical structure as what your body makes.
I would say that is the standard of care in the hormone space. If I've seen maybe once in the last 10 years, a really, really, really old doc who didn't know that these bioidentical hormones are readily accessible. They don't all have to be compounded. And he was prescribing some very old school regimen of non-bioidentical hormones. Yes. What's the risk of doing that?
Well, a lot of people, first of all, think hormones are bad. They're bad for you. You'll get breast cancer. You'll get this and that. But they are also referring to the 2002 Women's Health Initiative study, where they studied Premarin, which is horse urine estrogen, against Prempro, which is horse urine estrogen with a progestin. So progestins are chemically changed. They're not what we make in the natural form. But they found with that study that there was an increased risk of breast cancer in the women who were on the Prem-Pro, the combination. But the women who were on the Premarin did not have an increased risk of breast cancer. So they thought it was probably the progestin. And so there was maybe like 3 out of...
Progestin is the medroxyprogesterol.
Yeah.
Yeah.
3 out of 1,000 increased risk of breast cancer. So they said, hormones are bad, don't use hormones. And people went off and women suffered.
Yeah.
But we don't use those anymore. We use progesterone you can get at any pharmacy.
Yeah.
Or a compound pharmacy, micronized progesterone. And we use estradiol in different forms, creams, pills, patches, troches, rapid dissolve tablets. Just a lot of...
Comes in all different delivery
forms.
models. I want to mention that study. I want to say it was at one of my CME courses, continuing medical education courses. Marty McCary, like head of the CDC guy, he's like the head of research at Johns Hopkins before that. He's a surgeon, cardiothoracic surgeon by training, but does beautiful research and beautiful studies. And he spoke out about that study on breast cancer risk increased with hormone replacement therapy. And even though they weren't using bioidentical hormones back then, and there was a statistic increase in that number. I think it went from 2 in 1,000 to 3 in 1,000, or it was like a very, very mild uptick. And he said when you normalize the data, which you have to do in any good study, it actually didn't show that. And he actually called out the lady who started shouting from the rooftops that, this is happening. Yeah. And she actually ate crow and said, you know what, you're right. And I think that's very significant. And it's still on the black box warnings. It's still all over all the medicines. But it's because of that one study. Yeah. And I think it's tough. That's a tough state, because then it puts us in a predicament as we're trying to reasonably advise people. And, I think we do shared decision-making process with most all of our clients. We talk to them, whether it's a procedure or it's a new medicine or it's a surgery, or, we talk about the risk, benefits, alternatives, and there's always a scale to weigh out and decide, is surgery worth it or is it not? And so we have a discussion and we do some shared decision making. And that process for hormones is very difficult because some of these institutions continue to hold on to that dogma. And even the black box warnings are still holding on to some of those dogmas. And so it makes it really challenging.
Those warnings are on bioidentical hormones, and progesterone does not increase the risk of breast cancer. It's breast protective. And
totally.
Estradiol either. So,
what is the general risk of breast cancer among females?
I heard one place 1 in 4. That might be a little bit high. Do you know?
I've heard 1 in 5 and 1 in 7. So it's one of those. I'm going to query that.
I always say, you never know. Maybe you would get it on your own or through family genes or something, but to keep your mammograms current. But you do, if you are on the hormones and if you did develop a breast cancer, being on the hormones could fuel it. So, but not necessarily cause it. Okay.
In the United States, according to the American College of Obstetrics and Gynecology and the American Cancer Society, it is 12 to 13%, about 1 in 8. So we were both wrong. but that's really common.
That's better than 1 in 4.
Yeah, but that's still a lot of people. And so, and among like BRCA1, BRCA2 gene holders, it's up to like 40 to 45, 65%, much, much higher. So I think as we're navigating these waters, shared decision-making process with people, understanding that it's so common. And like you said, stay up to date on your mammograms, like get those. What is the guideline? The guideline of mammograms now has changed too. It used to be starting at age 40 every year. But the guideline has changed to starting at age 50 every 2 years if you don't have any significant risk factors. And that's the United States Preventive Services Task Force guidelines. And so that is considered reasonable screening. ACOG and the American Cancer Society disagree with that guideline.
Yeah.
And so there's some headbutting among PhD people. And so to me, again, shared decision making with my patients, I tell them, well, the United States Preventive Services Task Force suggests this is okay, but ACOG and American Cancer Society say this is okay. What would you like to do? And as long as you don't have a family history. If you have a significant family history, then it is much younger and it is annual. And that's what we are. We're like primary care specialists. We do screening, health and wellness. That's our jam. We try to help people live as long as possible with as high quality of life as possible and healthy. Yes, exactly. So I just think that's a significant thing to talk about. And then maybe we could talk about, we talk about maybe some of the risks. Are there other risks to some of these hormones?
I usually on people on testosterone, especially if they're on the testosterone cypionate or, the injectable, I usually watch for cholesterol levels and liver enzymes because those can increase. They don't increase if you're on the natural testosterone, like at a compounding pharmacy, like a cream.
Oh, yeah.
Those don't increase with that, but they can on the injectable. So I usually watch for that.
Have you seen that? I've never seen that. I mean, I've managed them both ways with folks, but
I haven't seen a big bump. I've seen maybe a little bit in their labs, but
the other risk I can think of, if we're just doing estradiol, bioidentical estrogen, and the woman has a uterus, there's a little bit of risk there to endometrial cancer if we don't inhibit that risk with progesterone. And again, people who know hormones, again, I would be smart. If you're thinking about hormone management, talk to someone who's really pretty knowledgeable in that space. Someone like us, where we can help them mitigate some of those risks just by adding progesterone. Yeah. So simple. And blood clots, can we speak to blood clots and estrogen?
I was going to say that. With the oral estradiol, it's cheap, it's nice, it's bioidentical, but it does go through the liver, and you can have an increased risk of blood clots with that. So we watch that, and especially if somebody, has really high cholesterol, they're probably fine if they're doing oral estradiol around in their early 50s, but maybe later, and if they have high cholesterol, high risk of blood clots anyway, maybe I would probably do the patch or a cream.
A topical.
It doesn't go through the liver, so maybe consider it a little bit safer.
Anybody who smokes is contraindicated for oral estrogen. Anybody who has a family history of coagulopathies, clotting disorders, even if you've had a clot in the past, it's just off for you.
In the oral.
In the oral, for sure. So those are the big pieces. Testosterone in females, I mean, if you're overdoing that, there's, you can have permanent voice changes, you can have facial hair stuff, you can have acne stuff. And that's usually in pretty high doses, things like that.
Yeah, and we'd like to stay in normal ranges. I usually like to optimize into the upper end of normal, or depending on how they're doing too and how they're feeling, their labs would be like upper end of normal, not just barely into normal, because there's some research showing that, an estradiol level of at least 60 is helpful for your bone density. So if you're at a level 50, it's not doing you much good for your bones. Oh,
one more thing. We're just finish up on risks, and then we're going to talk about the slew of benefits, because there's a whole bunch of benefits. Testosterone also sometimes causes some erythrocytosis, some extra red blood cells. So therefore, just a little thickening of the blood could be, and that could predispose folks to maybe forming clots or even low blood flow state stuff.
And there is a difference, though, between erythrocytosis and polycythemia. Both can have an elevated hematocrit, but polycythemia is more dangerous because you have elevated platelets, and so you can have the blood clots with polycythemia.
Yeah, and people misstate that all the time. You're polycythemic. I've seen docs say that. I'm like, No,
when they're not.
Their hemoglobin, hematocrit are just up a little. Their platelets are normal and their white cells are normal. Polycythemia is multiple cythemia, blood cells elevated.
And you might see somebody that lives high up in the mountains with erythrocytosis just because, low oxygen, and they're making it up with their increased red blood cells, and it's not dangerous, and they're not.
Last year, I hiked around at 10, 11,000 feet for many, many days, and I had erythrocytosis. I had elevated hemoglobin hematocrit from being in the high elevation, and it's a physiologic response to low oxygen state. Your body's like, hey, we need more hemoglobin to carry more blood, to carry more oxygen to the cells because you're in a low oxygen state. Smokers get that. People that live at high elevation get that. And people that hunt mushrooms at high elevation get that, like me. So yeah, I think that's good, and that's a good distinction. Let's pivot a little bit. Let's stay in the female lane, and let's talk about physiologically maybe some of the benefits of some hormones in certain age groups. So I'm gonna start younger because just this week I saw a gal. She's 35. And she has hormonal acne every time during her cycle. It's really bad. It's cystic. It's bad. And so she has this hormonal acne situation. And so largely it's from some of the spikes and stuff in their testosterone levels during ovulation. And so to treat that, we generally can use like oral contraceptive pills, which are a little bit of progesterone and estrogen, and then it stabilizes those spikes, so they don't have those big spikes in their testosterone levels.
You can also treat that with spironolactone.
Yep, and that's what we did. We did both those things. She actually didn't want to do the oral contraceptive pills, so we just did spironolactone for her, and a bunch of other stuff. But yeah, the hormone, that's like the younger hormone space. What about like PMS, PMDD?
So PMS often. Your progesterone's supposed to peak around day 21-ish of your cycle on a person with 28-day cycles. And then it starts coming down. Some people can get this really PMS anxiety, crying, irritability before their period. And progesterone can help that. If you sustain the progesterone a little longer, it can help with those symptoms. So we often use that one like day 14 through 21, 14 through 28 of your cycle for PMS. And that works pretty well because it's also calming. It helps you sleep. It helps anxiety. And then they just start day 14 through 21. It helps quite a bit.
Yeah. I use it too. It's great. Micronized progesterone, bioidentical, large, readily available, and very inexpensive, even without insurance, very affordable.
Comes in a couple doses, and you can kind of tweak that. And sometimes we'll use a lower dose in the beginning of the cycle, days 1 through 13 if they need it, and day 14 bump it up, or just usually for PMS, day 14 through 28, some progesterone, and then we find the dose that kind of works for them. They feel good on. You want to feel good. Yep. And have it be helpful.
Premenstrual dysphoric disorder, PMDD, pretty common. Similar PMS. It's like PMS, but times 20. And some people get very dysphoric. Some people get even psychotic. Like it can be very, 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 very bad. Progesterone in that almost the same as far as utilization, same mechanism of the way that it works as well. Yeah. Anything else to add on?
You could add some of the SSRIs are good at that, and you can use those every day, or it's day 14 through 28. But I usually have good luck with progesterone. Yeah.
If contraception is in your wheelhouse, then OCPs will help as well, because they help with those peaks and valleys. So they kind of help stabilize those. Yeah. When I trained, they used to say you can only be on OCPs for a certain amount of oral contraceptive pills. OCP, sorry, I keep using that acronym. You can only be on them for this many years, or else it poses a risk of XYZ. And I recently visited the data on that, and it's actually not true. You can be on those pretty safely, indefinitely, as long as you need them. So that was an interesting change your mind factoid thing. And
things always change.
Yeah, and that's the cool thing about science is it keeps adapting and it keeps changing. And I truly hope that if we look at the data, and as we do that and look at it again and again and again, and are willing to change our minds about hormone replacement therapy, more people will have access to these hormones. And the reason why is we're going to follow that. So why are these hormones so helpful as perimenopause or even menopause or postmenopause? Let's talk about each one for those scenarios, or just menopause. Let's just talk about menopause in general, because peri is like I'm getting close to it, menopause is I'm in it, and postmenopause is I'm through it. It's all brutal. It's all ovarian failure. And unlike males, whose really their gonads generally don't fail over time, they will sustain. I saw a guy, what is he, 80 something, and his testosterone was like 700.
Wow.
And he's just maintaining testosterone and just doing great.
Wow.
We are seeing some bumps in the male testosterone space, and I have some theories and some ideas as to why, but there's a little bit of studies out there. We'll talk about that in a minute. But let's stay on the female hormone replacement therapy. Let's break down each one, and let's just talk about physiologically how they help us.
So just perimenopause, people may start noticing changes or symptoms in their 40s. They're still maybe having periods that might be more irregular. They might be farther apart, closer together, lighter, heavier, kind of anything goes. And depression, moods, mood swings, and that's, progesterone starting to go down. And so you have some of those changes, and they can start having night sweats and hot flashes and maybe vaginal dryness, but a lot of kind of irregularity. And that in that case, progesterone's really great because people really love it. It helps you sleep, and it helps a lot of things, anxiety, and it can help lighten periods. It can help maybe regulate them a little bit better when they are on the progesterone, and then they get closer to 50-ish. Typical menopause is 50, 51. That they might start getting symptoms again, like hot flashes and night sweats again, and time to check the estradiol. But usually if we check it before that, but because that can start going down. And menopause is 1 year without a period. So we check levels and see where the estradiol is, testosterone, progesterone, DHEA, and it might be time to add a little bit of estradiol, and then that can change too. That can vary over time as they're transitioning into menopause, where they might need maybe a little bit, but not quite enough, like in a menopause range. But so I usually will start with progesterone and maybe add estradiol later if we need to. Mm-hmm. But and menopause, all the hormones are like zero; they go way down, and you feel crummy, you feel tired, foggy brain, you don't sleep well, anxiety, hot flashes, night sweats, vaginal dryness, all of those things. And the hormones can help with all of those symptoms. So I usually go off of the labs and what the person's level is to kind of choose dosing. But there are a lot of benefits. They do help the PMS and the perimenopause symptoms and the hot flashes and night sweats. And estradiol is really good at vaginal dryness, hot flashes, night sweats. Progesterone helps those things, but really helps the sleep and anxiety.
It's so fascinating. I just saw a gal today, 51, and she's like, I've never had anxiety. And now I'm over responsibility-ing everything. Like my daughter has this thing and I get super anxious about it. And my son has a thing and I'm way worked up about it. And she's like, I'm not this. This is not me. Yeah. And I said, well, this is super common in menopause. And sure enough, just like you described, the menstrual cycle is the litmus test of menopause. So if it starts changing, lengthening, skipping, shortening, all of those things are signs that you might be heading into perimenopause. It's happening earlier and earlier in females. I'm seeing it in younger and younger mid 40s. It used to be 50s plus, and it's generally occurs over a few years, and it's a slow
it can go
process.
on for 10 years even.
It's brutal. But progesterone, I think there's a couple of things I want to point out. One is the the osteoblast activation, so bone mineral density, which is really cool. And the other one is the neuro effect, like you mentioned. It's like a neuroprotective effect, improves sleep quality, alleviates anxiety and depressive symptoms. And I think those are the big ones for progesterone. I love what you said, like as someone's perimenopausal, you may just start with progesterone. It will help you feel less crazy. It will help you with some of the bone mineral formations and some of the emotional stuff. Gosh, in medical training, sometimes they're just like, well, if they're heading towards menopause, you should just start them on an SSRI, which is interesting. I think medicine is wonderful and beautiful and fun and lovely, but sometimes they get stuck in a dogma. And it's really important for us as healthcare providers to be able to visit the data and reshape that thought process, change it.
Yeah, the hormones help a lot better.
They help way better.
And they help more things.
You don't need that SSRI, you need progesterone.
Yeah, and it helps your bones. Estradiol. I have a handout on what the different hormones do. I was going to bring it, but I didn't. But it helps your memory, both of them. Estradiol, progesterone helps memory, bone density.
Estradiol.
Yeah.
No, for sure. Yeah. It's like the main player in the bone mineral density. But I didn't know progesterone does that too, but it does. Yeah.
And both of those, testosterone also helps bone density in women. So, and helps your vision. It helps just sense of well-being. All of those, estrogen, testosterone, progesterone. Testosterone helps libido. It helps climax. It helps bone strength, muscle strength. Not that you're going to get buff and have a beard, if you're on testosterone for women. We just use a fraction of the dose that men use. And again, staying in normal ranges. But where they feel good, they notice you might be able to pick things up a little easier, have more endurance and energy on the testosterone. Yeah. And sleep better, and your mood's better if you sleep better on progesterone and you're not waking up with hot flashes and night sweats. Something that's interesting is the estradiol modulates our fuel metabolism, and it favors fat utilization, especially during like level 2 cardio, like walking or those kinds of things. A lot of people during menopause, they gain this fat in these weird places, and they're like, what's going on? Where estrogen is so low, they're no longer preferentially utilizing fat. In general, we do that. Like on low intensity exercises, our body tends to favor fat utilization for energy. And estradiol does that, and it helps regulate body weight and energy expenditure, which is fascinating. Yeah. It also makes skin and hair and eyes and all these things more elastic and beautiful. And vaginal dryness. Dryness. Helps prevent UTIs, bladder infections. The elastin in our skin, it stays longer and is better on these hormones, but also in our blood vessels. So our blood vessels they're an epithelial layer just like our skin is. And if it's more elastic, then it can tolerate more and give more, and therefore prevent hypertension. So one of the mechanics of hypertension as we age is that our skin gets more tight and taut, so do our blood vessels. And so as they're more taut, they're less able to acclimate, and the pressure in those increases. And so that's another interesting little tidbit on estrogen. But they also help skin, like estradiol, testosterone help fine wrinkles. Totally. If you were looking at like amount of estrogen versus amount of testosterone that females produce, I think it's fascinating. The units that they use to measure estrogen are actually quite a bit smaller than the units that they measure testosterone. So it sounds like estrogen is like 70 and testosterone is only 20, but the units are different. So actually the ovaries produce more testosterone than they do estrogen, but we just don't ever think of that. And so a lot of docs and other providers out there are remiss at supplementing testosterone in females. And let's talk about that briefly. They don't think they need it. Yeah. Yeah. Just ask their husband if they need it. Yeah, it's dogma. and they would say, yes.
Yeah.
give her some.
Yeah.
And she'll feel better, just better kind of general energy, better well-being, strength, endurance, and all the other benefits of libido and things. I think maybe we're nervous to do that because we don't know how to use it in females.
Yeah,
do you
I
think?
think it's just dogma, honestly, because all through med school, they never even talked about it. Never even hit on it.
Yeah, because women don't need
there's-
testosterone.
And all in the treatments of anything, it's all OCPs, which have no testosterone in them.
Yeah.
And even
and they reduce testosterone.
Totally.
Yeah.
And even in post-hysterectomy, oophorectomy patients, they don't replace testosterone.
Or progesterone.
It's super frustrating.
Yeah.
Yeah.
So I tell my patients if they need a hysterectomy, their doctor's going to take them off of progesterone, but you don't need to go off of progesterone because it's helping you sleep, it's helping anxiety.
Right. All they're thinking about is that endometrial inhibition or protection, and it's so myopic, right?
Right.
They're
and
not
if
seeing
you
the whole
don't have a
picture.
uterus, you don't need progesterone to protect the uterus, but it does so many other good things. Stay on it. I tell them, stay on it.
Yeah.
Stay on your testosterone.
Yeah. But they're still working under the dogma that medroxyprogesterone in this study may have increased breast cancer risks from 1 in 1,000 to 2 in 1,000. But when you normalize it, that actually doesn't. But they still go off of those black box warnings.
We can't get away from that.
And
How come?
ACOG and all these other folks are still leaning on that.
Yeah.
And it's frustrating. It's frustrating when we're stuck in something that is like a little bit of ambiguity.
Yeah.
And unfortunately in medicine, ambiguity creates lawsuits, and it's a bum deal. It's a bum deal. And then it creates trepidation for doctors to do things that are reasonable, but there's a black box warning against.
Yeah.
And I'm not going to go into the black box warning.
Well, there's a black
'cause then
box
it's-
warning on estradiol, the same that was on Prempro,
Exactly.
which
It's inappropriate.
it's not the same thing.
It's not the same drug. Yeah, it's inappropriate. But they've just kind of blanketed it across the board. And I used to be in that dogma. I used to be thinking that way because that's what I was trained. That's what I was taught. This is, you use these hormones for the minimum amount of time possible to help alleviate the lowest dose possible to help alleviate these symptoms. They're just playing a mitigation game of risk, and they're not really thinking about the studies and the physiology and the way this hormone works and what else does it do in this person's body.
And we want good levels. We don't want just barely normal levels. We want good levels that actually will benefit you. And we want good progesterone levels so that you don't spot and bleed.
Yeah. I think there's a ton of studies showing, we're just still on the testosterone for a minute. There's lots of studies showing longevity and quality of life enhanced with muscle mass. And as your testosterone shrivels to nothing, it is really hard to maintain any semblance of muscle mass and gain it.
Especially after the age of 50 where your muscle mass goes down anyway.
Yeah. So pretty cool implication for testosterone, and not only the relationship, libido, sexuality, and all those upsides, but also the muscle and bone strength that creates too. It doesn't do it magically. You still have to do some work.
Yes, you do. Weightlifting, protein.
Yeah. But a game changer. In the sequence of events of perimenopause, menopause, postmenopause, at what point do you generally start testosterone? I mean, progesterone, we start kind of right away because ovaries aren't completely failed, and they still have maybe some testosterone, maybe some estradiol, and we kind of watch that and then listen to their symptoms. But is there a time when you're like, hey, you would benefit from this?
I usually go by their labs and their symptoms. But you have to be careful. Like if you can still get pregnant, in premenopause, you have to be careful because you don't want to get pregnant on testosterone. So usually I have them say, use some kind of contraceptive or something, so that's something to keep in effect too. But totally menopause where everything's zero, no periods for a year. Then I start people before that too, depending on their symptoms. Just with the cautions.
Yep. Is there an inappropriate utilization of bioidentical hormone replacement therapy that you've seen as well?
I would say, you want to monitor levels. Just don't start something and say goodbye. You want to monitor levels and see if your doses need to be tweaked, if they're too high or too low or not in balance. So I think follow through is good, and you don't need super levels of estrogen and testosterone and progesterone. I think if you're not followed, and if your level's just wacky and they're out of balance and you got way too much of something, that's not good either.
Let's talk about levels, because if you pull up on Google Images, I do this sometimes for my patients. If you pull up female hormone cycle pattern, there's a graphic there that shows you what their hormones do over the course of this 28-day cycle. And so with all of those highs and lows, how do you know if you're getting a decent level? When do you generally check which hormones and then say, okay, at this time of your cycle, this hormone is inappropriately low?
Well, I usually check hormones on the 21st day of your cycle. That's when progesterone peaks. So that's usually when I do that. And I just check all the hormones at that time and go by their symptoms too. I don't jump into estrogen really fast at first in perimenopause, because if you give too much estrogen, they're just going to be really irritable. Breast tenderness, bloating, grouchy, acne. So
that one is going to be like day 14 to 16 of their cycle. Maybe down the road, if they're having some symptoms, maybe we check it next cycle, because we got your progesterone dialed, your perimenopausal, we got your progesterone dialed, and so now, you're showing me some symptoms of maybe estrogen testosterone deficiency. Let's maybe check that mid-cycle, see where that's at. And I generally see it drop off, like in menopause. LH, FSH, can you speak to those as well, like with regard to perimenopause and then menopause, what those numbers do?
Yeah, so FSH is a marker for menopause, follicle stimulating hormone. So that usually goes up in the first half. LH, luteinizing hormone, usually goes up in the second half. You see FSH go up when you're getting closer to menopause. So if your level is 50 FSH, then you're probably menopause. If it's 30, you might be kind of pretty close, but not quite there. If you're 3, you're not close to menopause.
Right. And this is part of the inappropriate use of these hormones that I've seen. I've seen folks whose LH, FSH is clearly not in the peri or post menopause, and they're starting them on these hormones. And it's just not appropriate. It's like someone who's maybe half taught or they half learned it. And to me, if you're cycling regularly, don't use hormones.
You probably don't need hormones.
Don't use them.
Unless you need it for PMS or something.
Use a whole bunch of other things to address your energy and mood and all these, the hormone regulation. There's a whole bunch of like nutrition, vitamin D. There's a whole bunch of other exercise to like normalize your normal, optimize your hormones perimenopause if you can. Before you hit perimenopause, there's lots of things you can do to optimize your hormones, but bioidentical hormones are not one of them. I've seen folks on the pellet get pregnant and have teratogenicity or birth defects of the babies. I've seen lots of side effects to these young gals that are. The problem is similar in the male space because it is a performance enhancing drug. And so some of these hormone shops are just like, put everybody on it, even the young ones. And they're just causing a ton of side effects and inappropriate use of them, frankly. So I don't know, it bears discussing briefly. There are risks and there are some inappropriate utilization of some of those things.
And there are times to use it and times to not.
Yeah, totally. Okay, so I think that's Is that everything for the female hormone replacement space? We could talk a little bit about compounded. I think the testosterone for females, you can get the gel, non-compounded, the testosterone gel. The compounded creams are fine. You can
this natural testosterone.
You can combine the testosterone and the estradiol. vaginal application has a bunch of upsides, like the vaginal mucosa is happier. There's a bunch of a lot of upsides to that too.
You can use for compounds. You can combine estrogen, testosterone. You can put progesterone in there. You can put DHEA in there.
Yeah.
But you can use them in a troche, like a little tablet vaginally. That's usually absorbed pretty well. Not everybody likes those, but you can also combine things in a cream, or you can use estradiol patches and oral progesterone. You'd want to use oral progesterone because that helps with sleep best, and separate testosterone cream. So there are lots of options. You can do troches, little tablets that you dissolve in your mouth, or rapid dissolve tablets. So some of that depends on how well you're absorbing things, the route that we choose first, and then tweaking things to do a different route if we need to see if you absorb it better, because we do want good levels.
Yeah. The compounding pharmacy, which we just did a podcast not long ago with one of the compounding pharmacists, and they've changed the game because we can really dial in those numbers, because we can say, well, she's not absorbing it, she needs a higher dose, or she's absorbing it really well, she needs a lower dose. Yeah. And that's pretty rad. Progesterone generally orally. A couple of tips there. Take it at night before bed. Yes. But after sex, because it can mess with the sex thing a little bit, because you get all sleepy and all that.
You want to make sure you go to bed at a reasonable hour. Don't take it and wait forever. Wait an hour or so to go to bed, because then you'll start feeling kind of dizzy and loopy. Yeah. But, I'll often start, maybe it comes in 2 doses, 100 and 200 that the pharmacies give, any pharmaceutical companies make. Yeah. And some people are sensitive, some people are not. I usually start maybe a little bit lower and say, okay, after a couple of weeks, go up a little higher, but watch for these things. Yeah. And you usually get used to it after time. But if they're not, we just go up slower. And that's where you can use a compounding pharmacy, because they can make it in whatever dose we want. Yeah. They can make it in 110, 125, 150, 175. So you can, if someone needs to go up slower, you can use compounding pharmacy while you're trying to get your dose
There's a little bit more cost with compounding with progesterone. It's super cheap through any Smith's or Costco or any of those pharmacies.
That one from the regular pharmacies is peanut oil based.
Okay, so if you have peanut allergy, be aware.
Then you should probably use the compound, which is, I like to use the yam. They do yam or soy, but I like the yam. Okay. That's usually compounding pharmacies.
That's good stuff. I think those are the main tips. I think that's pretty much female hormone replacement therapy in a nutshell. If I can make a caveat, this is not intended for medical advice. This is you and I having a nice conversation. Yes. Please talk to your doctor. Yes. And please talk to your provider and make sure that they're well trained in hormones. I think some folks are just like this much trained, and some folks are this much trained. And I would say that you've had certainly more experience with this than I have. You've been around the block longer than I have, but I've done a lot of hard work to get up to speed on bioidentical hormones. What do they look like? I had lots of continuing medical education courses, and I think the docs probably they all need more training in that space. In my experience, like many of them are still dogmatic about their thinking and about their treatment regimens and all of that. It's best that they stay out of it, honestly, unless they go out and get real training. True. There's North American Menopause Society. They offer some decent hormone replacement therapy for females. Just a decent course. What are some other courses that you like?
There are lots around, and I've been to kind of different ones, and you get one view here and one view here, and you kind of put them all together and see what works. But out of just North Salt Lake, there's World Link Medical, Dr. Neil Rosier, and then there's Pamela Smith. She's with PCCA, and she gives lectures on hormonal things. And there's A4M. That's another group. So Dean Jolly does continuing education. He's a pharmacist up in Salt Lake, Bioidentical, and he hosts training through him too for providers.
I just wanted to throw that out there, so folks that want to learn more, they can go to some sites and get certified or get at least reasonably trained on things and look at the data, look at the evidence. It's cool. I don't know that we have a ton of time to talk about male hormone replacement therapy, but let's do it anyways.
I'll be quiet and you can talk.
No, we'll just do it really fast. So the American Urology Association put out a really good paper on it. If you're a healthcare provider, I would advise you to read that because it clarifies everything. American College of Obstetrics and Gynecology have not done that. The North American Menopause Society have not done that. They need to put out a paper saying it's reasonable and it doesn't actually cause this and it does actually cause that. The American Urology Association did, and it's wonderful. So it really like gives you solid footing to stand on and use these medicines for males. So the gist of it is a whole bunch of things cause a physiological decline in testosterone over males. Males' testosterone will be highest in the morning, and it normal physiologically declines over the day. With that being said, generally when we try to diagnose hypogonadism, we'll do it in the morning. And if it's low, then check it again. And then if it's still low, then we should do it in conjunction with like a pituitary test to make sure that it's coming from the gonads, not the pituitary, because there are primary and secondary hypogonadism. And that way you parse that out.
Which test do you do for that one? The prolactin?
Prolactin is helpful, but that's really like screening for like a pituitary prolactin screening one. No, I do. I check I just check their pituitary sex hormones.
Yeah.
I'm blanking. Sex hormone. No, I forget. Dang, it's outside of my brain right now. But anyway, I check the pituitary and make sure that it's stimulating the boys, or LHFSH. So I'll just check the males' luteinizing hormone. Is it stimulating the testicles appropriately? And so if it's low, and this is low, so your pituitary hormones are low, and your testosterone is low, well then it might become premature pituitary because it should be higher if it's trying to stimulate those guys. Normal testosterone males, I mean, if you look at the normal data, it's going to say like 280 to like 800, depending on ages. Young kids is much higher. And then free testosterone is really important because there's a thing called sex hormone binding globulin that can bind up their testosterone, and their free testosterone will drop. And they'll feel low testosterone symptoms. But what a lot of these, there's a hormone shop on every corner in Utah County. And these guys put 100% of the people that walk through the door on testosterone. And I have ethical dilemmas with that. But they're largely treating a lot of people that if they just did some lifestyle things, they could really correct that free testosterone issue that they're having. Can we speak to that? Do you want to speak to that a little bit? The lifestyle stuff that helps with sex hormone binding globulin?
Well, often you see a high sex hormone binding globulin in people who are overweight or have a lot of
metabolic syndrome,
calories,
the American diet, the stress levels, the carbs, the pre-diabetes, the diabetes, the obesity epidemic is moving everybody's sex hormone binding globulin up, which then is causing this drop in their free testosterone. What is dropping their production of testosterone? What is causing primary hypogonadism or the low testosterone in America? Interesting podcast. Huberman interviewed the gal. She's in her 80s. She's been doing these studies for 30 years. They're ongoing studies. And they're all the things my mom told me when I was little. Hey, son, don't eat out of that plastic thing. It's going to hurt your body. Hey, son, don't spread that insecticide in the lawn. It's going to hurt your body. And both of those things, actually, many, many years now, have been shown to decrease male testosterone. Almost all of our things are plastic. Almost all of our packaging, everything is in plastic stuff. And so that, in my opinion, I think that is driving a lot of that insecticides on our fruits and vegetables.
Might be junk food too, junk, the chemicals and a lot of junk food.
In America, we have more additives than any other country. In Europe, you have to prove that an additive that you're using or a packaging that you're using is safe before you can deploy that. In America, we don't do that. It's post facto. like this gal has been doing this study for 30 years only to prove that it actually does that.
Yeah.
And so anyway, it's a fascinating podcast. There a little bit of hubris there, but it's super cute. Yeah. But she talks about it, and so I think it's one of the theories. I think there's stress. That's a theory that's in that as well. We're not good at
sleeping
stress.
well either.
We're not good at sleep. We're all the energy drinks, messing with our sleep and our circadian rhythms. There's a whole bunch of pieces to this puzzle. But it's common. And so hypogonadism, very reasonable to treat in males, as long as you've checked all your boxes and make sure that you're doing it correctly.
Well, and some people might have the question, well, does it cause prostate cancer?
Oh, yeah. The AUA in that paper specifically said does not cause it. And that's beautiful. And in fact, I had a patient come to me from a urologist office who that urologist treated their prostate cancer and put that person on testosterone for hypogonadism. And I was, whoa, because we're checking PSAs and it sure made me feel better. So I was like, well, I'm a little hesitant on that because we were taught that it does cause this, but actually the data shows that it doesn't. And the AUA has the stones, pun intended. They have the gonads to make that statement, to actually say that, which is really cool.
Yeah.
Really cool.
That is relieving.
Yeah. Now, inappropriate use, 100%.
Yeah.
There's a testosterone mill in every corner. There's like 35, 25-year-old people doing it unnecessarily. If you're low testosterone and you're doing all the physiologic things, you're working hard, you're getting vitamin D, you're managing stress, you're exercising, you're doing resistance training, you're eating reasonably, and your testosterone is low still, you're going to feel some symptoms. You're going to feel low libido, low drive, low energy, depression, the psychological effect. It's huge.
You fix their testosterone and the depression gets better.
Central obesity. There's a bunch of fat deposits that change in different areas off of that or when that starts changing. And so it's really neat. And the area of hormone replacement therapy for males is also very tricky because it's a performance enhancing drug. So all these testosterone mills that put these guys on testosterone, they all feel 100% better. They're like, oh, I feel great. This is awesome. I've never, been able to work out like I work out now. I'm feeling much better and I'm 35. What they don't understand is that they're shutting down their boys, their own ability to produce their own testosterone. And it could be permanent. Permanent. Yeah. They'll shrivel up and they'll get smaller and smaller and their ability to produce it is even lower.
One way to get testosterone up without shutting off your own is using Clomid. Mm-hmm. And you could use just Clomid and no testosterone.
Yeah, speak to that. Want to speak to it?
Sure.
What is it? How does it work?
Clomid
or Clomid, either one.
Yeah. So it kind of, if you're on testosterone supplements, it'll tell your brain, you don't need any more testosterone because you've got enough. So your body just kind of quits making it. So you can have testicular atrophy. If you're young and want to have kids, you could have infertility if you're just on testosterone. But Clomid kind of breaks that loop so that you kind of blocks that loop, I guess, so that you make your own testosterone still. So if you're just like on some of the younger guys that are having symptoms and their levels are low, I might just start them on Clomid. But you can also use testosterone with Clomid to help prevent testicular atrophy and to help prevent so you don't shut down your own fertility and your own testosterone.
Can you speak to HCG a little bit?
That can help do that too. Clomid and HCG.
Yeah, they're kind of both analogs, pituitary
HCG
analogs.
Would be a shot, usually, and Clomid would be a pill. Clomid is an estrogen receptor modulator, a SERM, and off-label use for low testosterone in young males. I like it for hypogonadism in young males because I'm preserving fertility, getting their levels up reasonably. We talk about risk benefits. It leads to the increased secretion of LH-FSH. And so that it stimulates testosterone production from the pituitary instead of the gonads, or instead of inhibiting them, because you're right, if you inject it, then it inhibits the LH-FSH process. No, that's awesome. I think those are all good tips and tricks and good pearls. You can use testosterone injections once a week, once every 2 weeks. You can also do
testosterone topically as a cream for a more physiologic response, like on a daily basis. Testosterone does this. If you do it weekly, it's like on a weekly basis of a peak and valley. Yeah. And 2 weeks, it's a bigger peak and a bigger valley. So we generally try to dose it, once or twice a week, and then injection versus daily creams. Are you seeing good results with the creams on guys too? Me too. I think they work fine. They have the Axiron gel that you can put on their armpits and the testosterone stuff there. Any other tips and tricks on male testosterone or anything?
I just check levels and, adjust as needed.
Yeah, and I think the risk is going to be monitoring that free testosterone and then also monitoring their hemoglobin hematocrit, looking for that increase. If it starts getting too high, we might need to drop the dose a little bit, make sure it's more physiologic for them. Expectations are important, and I think helping people understand, let's be realistic here. We're not going to make you 16 again. But we'll get you reasonable, Yeah.
Yeah. And it can take a little while, a few months to really regulate levels and get them where you want them. Adjusting doses, just depending on how people absorb things. And so it can take a little while at first to dial in on it. And then once you've got it, then you still do want to check labs periodically, but you don't have to do it as much.
Yeah, totally. Well, Marilyn, this has been so fun. I'm glad we could just kind of briefly gloss over some of the hormone space and just talk about, the risk to benefit ratio on some of these things and appropriate utilization of them, maybe some inappropriate utilization, and talk to your provider about them. If you're thinking about hormone replacement therapy, obviously, if you're in our neck of the woods, come to us. We do that all the time at Voyage Clinics as needed, but also in other necks of the woods, you can probably find a hormone replacement specialist. The NAMS people get this NAMS certification, North American Menopause Society, and then they're at least somewhat well-versed in hormones. And some of these other ones also have networks. I know WorldLink does their kind of network where they, I've been trained, and they'll kind of keep a network, and then you can kind of go there and find someone who's reasonably trained in hormone stuff. Cool. Anything in closing?
No, I don't think so. I mean, I've just seen people feel so much better on hormones, and I think it's their quality of life is much better.
Totally. It is not all about lengthening life. It's about that quality of life as we age. And I remember with my wife going to a cruise ship and seeing all the people, and I said, that person's on hormone replacement therapy. That person is, and that person. I could tell. You could just see their hair, their skin, everything is more vibrant and glowing, and they look better, they feel better, their muscle mass is better, they move better. What are we doing? Why are we allowing ovarian failure 100% of the time?
But people think, well, nature did it, so it must be right, and we'll just stay there.
Yeah.
And then they kind of decline.
Yeah. And there's nothing wrong with that. I mean, some people do that.
And some people want to do that, and that's fine.
That. Yeah. And we're not like gangster about everybody has to be on it.
No, we're not.
But yeah, I agree. I think there's some real upside, and that shared decision-making process is beautiful. It's really fun. Guys, I hope you learned some cool stuff on our podcast today. Thank you for your listening, and please like and subscribe and share with your buddies.